Good morning, everyone, and welcome to World Heart Federation's first Heart Cafe at the ACC 25, the American College of Cardiology's scientific sessions, which happen annually, and Expo, where the cardiology community meets to network, to learn, and to discover what is new in the world of cardiovascular health. WHF's Heart Cafe sessions are special because they're a space for honest conversations, they're a space without slides. All the knowledge is in our heads and in our hearts. All the science is there as well. And we are here to talk about what needs to happen so that the world achieves the vision of cardiovascular health for everyone, beyond what we can do as experts, physicians, cardiologists, other healthcare professionals, but also what the rest of society can do. And by rest of society, I mean politicians, influencers, decision makers, journalists, and the general public. And because this session will be recorded and will be promoted widely to a wider audience, I would like to ask my esteemed expert panelists to use language that will be very, very easily understood outside of these four walls. My name is Buriana Pervan. I'm the Director of Strategy and Communications at the World Heart Federation. It is my honor to host the first Heart Cafe and also to let you know that we'll have a total of 6 Heart Cafes. This is a tradition we started in 2019 and it's going strong. We are present at every major congress of our strategic partners. And I invite you to take a look at the rest of the program and join our other sessions that are happening today and tomorrow. With this one, I will open the first session, which is on strengthening cardiovascular health for all and commitments of politicians. The introduction that I will do before I introduce my expert panelists is that we all know that we are dealing with the world's biggest killer, but we are not sure if the efforts that every one of us puts are corresponding to the challenge, are corresponding to the damage caused by cardiovascular disease, to our families, to our economies, to our communities. So what needs to happen so that we have a proper plan on country level, or regional level, on global level, so that that plan makes sure that there is a commitment by politicians, there is budget to also invested, and that individuals are empowered to take ownership of their health. With this one, I'll introduce my panelists today. We're joined by Dr. Elijah Ogola, Dr. Vilma Izerola, and Dr. Salim Virani. My first question will be an opening question to all of you, and then we'll go into a deeper conversation, depending on, obviously, what's your expertise and your main area of interest. But the first question is, and I'll start with you, what is the #1 priority for you for this year?
For me, the biggest priority right now is the kind of work I do, which is I have shifted quite a bit from secondary and primary to more like primordial. So if you ask me, my priority is to actually move a lot of efforts we are doing into young adults, because then the dividends we get, they multiply. The priority, I think, for me personally is to move the needle a little bit towards getting our interventions and getting our programs into younger individuals, because the same intervention you do in a 40-year-old, if you take half of that in a 15, 20-year-old, actually get a lot more dividends. So rather than working on risk factors, let's work on people not developing atherosclerosis by moving the needle a little bit to younger individuals. So that to me is the biggest priority as far as I'm concerned, and the work that I do is concerned.
To start with, I agree with my colleagues' comment about starting really earlier in prevention for cardiovascular disease, and I think that we all know that cardiovascular disease and its risk factors are starting earlier and earlier in life. But at the same time, we thankfully are living longer. So we have the other side of the equation, which is aging, taking into account this whole problem that we have to face in my view, the priority is integrated care for people living with cardiovascular disease, because through the life course, and as long as people live longer, more and more long-term conditions are in place together with cardiovascular disease, and there are many complications related to these conditions. So my priority would be integrated care for people living with cardiovascular disease and other conditions.
Thank you very much for having me on this panel. You want us to have only one sentence for this, so I'll try to keep it to one sentence. And my priority going forward is to get more community ownership of cardiovascular diseases.
Thank you very much. Thank you, everyone. Now I will present you properly and we'll go into a deeper dive, what it means to strengthen our commitments as a community. So I will stay with you, Elijah. Professor Elijah Ogo is the president of the Pan-African Society of Cardiology, PASCAR. We are also very, very proud to have him on our board of the World Heart Federation as of this year for the next 2 years. He's a clinical cardiologist with research interest in the emergence of cardiovascular risk factors in Africa, and a passionate advocate for strengthening healthcare systems to address the growing burden of cardiovascular disease. You have worked closely with governments, with healthcare institutions, and international bodies, and you develop and implement evidence-based policies that improve access to cardiovascular care. Your efforts have led to increased awareness of hypertension, heart failure, and other cardiovascular conditions in the African communities. And my follow-up question is, given the rising burden of CVD in the African continent, it still remains, regardless of that fact, it remains underfunded, and compared to other diseases, and especially infectious diseases, communicable diseases, under-prioritized in governments. How can having a national cardiovascular plan change things, and is this the solution?
There is commonality of risk factors for various non-communicable diseases. So one of the tasks I had, does it help to go specifically cardiovascular, which is what this discussion implies, or should we do this in the basket of non-communicable diseases? There are certainly pros and cons. So being the diplomat I have, I said, you can eat your cake and have it. Because clearly, and I can give the example in my country of the cancer community. Because obviously cancer is a non-communicable disease, and we have commonality of risk factors and approaches to prevention. But because the people in the cancer community, and this talks to what I talked about the community itself, have raised the profile of efforts to create awareness, control mechanisms, systems to manage cancer, to the extent that in my country we have actually a national Cancer Act. So I was reflecting on that within this larger space of the non-communicable disease community, like Jesus said, in my Father's house there are many houses. So there are these many houses within the non-communicable disease community, and probably raising our voice about the specificities of cardiovascular disease, because our own statistics in Kenya, in Africa, elsewhere globally, cardiovascular diseases remain the leading cause of non-communicable disease control. In our environment, not yet the leading cause of mortality, because we have other issues that you are well aware of. So to then answer your question, I think raising the profile of cardiovascular diseases within the larger basket of the non-communicable diseases then aids the implementation of cardiovascular disease-specific efforts, mechanisms to control cardiovascular diseases. Thank you.
Thank you, Elijah. And let me just intercept here and say that we at the World Heart Federation had done an assessment, a desk assessment of how many countries have standalone cardiovascular health plans. And the figure is quite humble. We have only 16 countries who have these plans out of 193 assessed. And in terms of comparing with cancer, we have also estimated that 7% of countries have cardiovascular health plans versus 87% of countries who have cancer plans. So that gives you a little bit an idea of why we're doing what we're doing, and why there is still quite a lot of progress to be made. My next question to you still, Elijah, would be, given the constraints, the resource constraints in many African countries, what concrete strategies could be put in place, and what are the best practices that you had encountered to ensure that such plans can be financially sustainable over a long time?
Yeah, a difficult question when it comes to money. There are clearly economic constraints, but I think part of the issue that we have, especially in our countries, and some of the events going on globally right now might actually end up being a silver lining in the cloud. Clearly, we still have a big burden of communicable diseases. That is the reality, there's no question about it. But I think it fuels two things. One is perceptions and about the non-significance of non-communicable diseases. Now, this perception is enhanced by the fact that there is a lot of donor dependence in our healthcare systems, in our healthcare financing. And the donors specifically do not prioritize non-communicable diseases in their financing. So it creates a sort of vicious circle where, because our systems, our politicians like the inflow of funds from the donors, and the donors do not prioritize non-communicable diseases, so it helps to push it further down the ladder. Where does this story go towards? The fact that while we appreciate the importance of our development partners, and we implore them that, yes, people in low and middle income countries don't only die of malaria and TB and AIDS, we also get hypertension and depression and diabetes and all those things. But it's also an opportunity for us to develop local capacity and local investment, because ultimately that is what will be sustainable. And in this respect, this has been said quite a lot, how to convince our politicians, because obviously they control the purse strings, that expenditure in health is an investment that has got benefit not just from a human point of view, but from an economic point of view.
Thank you very much. I'll move on to Dr. Vilma Irazola. Vilma, you are the Director of the Clinical Effectiveness and Health Policy in Buenos Aires, Argentina. And you are also a Director of Chronic Disease Research Department. I think all of your bios are like 3 paragraphs long. But what is important to note here is your expertise as accomplished physician, researcher, public health expert. You specialize in non-communicable diseases, particularly cardiovascular health, diabetes, and stroke prevention. And you have been recognized for your extensive work in population health, implementation science. So we are going to talk about implementation of these plans and what does that mean and how do you make sure they're properly implemented, right? My first question to you will be focusing on the Hearts Initiative. So I would like you a little bit first to set the stage and explain about the Hearts Initiative and how it got established in several countries in the region, and how do you see within these the national CV health action plans complementing or can they integrate such initiatives such as the Hearts Initiative?
So yes, the Hearts Initiative have been successfully implemented in more than 30 countries in Latin America and the Caribbean. And this is an important initiative which is focused on management of hypertension in particular, cardiovascular disease, and other related conditions. And in terms of your question in particular, I think that national health plans, national cardiovascular plans in our country should work on the basis, building on the Hearts initiative to achieve, I would say, three important things here. The first one is the possibility of incorporating progressively all the components of the Hearts initiative. For example, we need validated devices to measure blood pressure, and because of limited resources in many countries or within each country in different districts, this is something that we haven't been able to implement completely. So that's an example. Another example could be fixed dose combinations of hypertensive medications in one pill. Not every country has this type of medication. So that's to me the first challenge that national health cardiovascular programs should address. The second one is related to scaling up. So we are starting within each country, working with different districts, but we need to scale up the strategy as far as possible, to reach a higher penetration within the region. And the third one has to do with monitoring and evaluation using data. And I would say high quality data, actually. The Hearts initiative has developed a digital tool that is really helpful for our countries to track and evaluate the progress of the program, both at the national level and individually. But we have to work on that to make these tools interoperable with our systems, our health data systems. So those are, to me, the three main challenges for our health national programs.
Yeah, thank you. I have a follow-up question on the measurement, because that's what we're most interested in. You said that there have been developed some tools to measure. Can you give just a few examples of these tools?
Yes, sure. Within the Hearts initiative, the program developed a digital platform where at different levels we can follow our progress in identifying, detecting hypertension in the community, which is very important at different ages, and also cardiovascular risk in the community. Then the link between the community and the primary care centers in particular. And within the primary care center, the number of people with hypertension and other diseases that are associated with hypertension and cardiovascular risk in general, and what is the proportion of people that, who is treated and who is under control as well. So through this platform, we can have data at the individual level, at the center, primary care center level, at the district level, at the national level, and that's so valuable. The second phase, I would say, is to make this platform, as I said before, interoperable. I mean, capable of taking a dialogue with the data in our national systems.
Similar question to the last one that I asked Elijah about sustainability and, especially in low and middle income countries. How do you ensure these plans are sustainable?
Again, it's a difficult question, the question here. And I think that we need evidence-based policies that are not only developed in each country, but also adopted, implemented, monitored, and evaluated. To me, that's a pathway to success. I work in implementation science, and we used to say that there is a no-do gap that we have to bridge, you know.
No.
We usually talk about a no-do gap, meaning that there is a lot of knowledge and evidence on the one hand, but it's difficult to translate that evidence into practice. So we have to bridge that gap. But in my opinion, we don't have only one gap, and we don't need only one bridge. There are several gaps and several bridges that we have to build. Because one thing is to design a good policy, but something absolutely different is to adopt that policy, to implement that policy. Implementers are far away from developers of the policies. So I think that we have to work on that. Implementation and penetration in the population of these policies, not only developing regulations.
Thank you, Vilma. What you said is absolutely key. It's about, you have a very, very long chain of actors, and how do you make sure that, throughout this chain there's a measurement, but there is also a quality control, and that, they talk to each other constantly and not just a one-off. So thank you very much. I will now give the floor to Dr. Salim Virani, who is a cardiologist, a researcher, and you currently serve as the Vice Provost of the Aga Khan University. You're also a tenured professor in cardiology and cardiovascular research at Baylor College. And you are known for being a public health advocate. You specialize in preventive cardiology, lipids, and CVD epidemiology. You have also made significant contributions to advancing cardiovascular care, improving prevention strategies, and reducing the global burden of heart disease through groundbreaking research, policy work, and clinical practice. I think that's the no being very well defined here through your journey. So my question to you, Salim, is, from your experience, what are some practical steps that countries can take to strengthen the healthcare system and the workforce capacity and support an implementation of such plan that Vilma talked about?
Yeah, so I'll give you a few ideas, but again, these are not new ideas, and again, there's a no-do gap for the governments as well. It's not just the clinicians, right? The governments know what to do, but there's always a gap when it comes to implementation. So first, I think we know that in a lot of countries that we're talking about, we don't have enough physicians to be delivering these preventive therapies that we're talking about, or in some cases even treatment therapies, right? So I think we have to first understand that we will have to have a cardiovascular care team that we will need. So we need to extend beyond physicians, make sure our nurses are part of this journey, and make sure if we have dietitians available, they're part of the journey. We need to develop strategies to engage community as well, whereby they can actually take care of a lot of that stuff. Because one thing working in our favor is that when we look at cardiovascular risk factors, you have a lot of these algorithms that you don't need to have a very, very, specialized training to deliver them, right? So I think one is leveraging the entire cardiovascular community and community in general. So that's one aspect of it that the governments can do. And I think it's been shown that it is doable. You look at the village doctor study for hypertension in China. I mean, they were able to bring down blood pressures quite significantly, more than 20 millimeters of mercury for systolic blood pressure. And even over a 4-year period, cardiovascular outcomes improved in those, more than 120 villages. But then you follow them for 5 years, even dementia-related outcomes improved in a population where the mean age was 60. So a lot of this is doable, but you need to basically leverage the entire cardiovascular community and community in general. So that's point number one that I would make for this. Then I think the second is that the governments need to have a plan as to how they're going to do it. It's very easy to say we're going to embark on this. But then understanding the healthcare financing bucket is a finite bucket. I can say that there are 100 medications that work, but if I take money out for cardiovascular disease, it's going to compromise on something else. So I think we have to go in thinking that some things will be affected. What are the things that we want to focus on? And I don't think that we as a cardiovascular disease community have done a very good job of actually letting people know. If you ask a common man, what's the biggest killer? I'm pretty sure you'll still find a lot of people who would not know that cardiovascular disease is number one killer. Most people die. I mean, right now we're hearing about 20 million people all over the world dying of cardiovascular disease. Well, if you look at countries that have a lot of conflict, I'll give you one example. The population of entire Syria is less than 20 million, right? But there are 20 million people dying of cardiovascular disease. So if we talk about these global conflicts, right? But there are 20 million people dying right now. If we actually just don't do anything about it, by 2050, 35 million people are going to die of cardiovascular disease every year, right? The entire COVID-19 pandemic, we had less than half of, these numbers of people who died, right? So I think it's that idea of providing that advocacy where the communities know, where the government knows that this is what we're dealing with. And then I think the cardiovascular community needs to come together and figure out what is it that we're going to focus on, right? And we can perhaps give 5 years or 10 years to each one of these risk factors. We know right now hypertension is the biggest one in terms of having bang for the buck, right? But then it might be cholesterol, it might be air quality, because even if you look at air quality, we're not, doing as much, working on it, but we know that 25% of heart disease, 25% of strokes are caused by air quality. And guess what? The countries that we are working in are the countries that are most impacted by poor air quality, right? So I think having some idea that you leverage the whole cardiovascular community, talking to the governments, figuring out, let's focus on one or two things, but then not losing track of some of these very emerging risk factors that are coming out, and they're going to become more and more important as we don't take care of the environment that we are in. So those are some things that I had.
You presented very well the problem and why we're here. Can you give us some examples of what works actually, and where can a country start developing, a country that is now embarking on a journey of developing a national plan? Where should they start?
Look, I gave you the example of village doctor study, right? This was not a study done in 5,000, 10,000 patients. This was more than 100,000 people, right? Done in villages. So I think that's one example where it doesn't have to be the government, even the private sector can get in and get a lot of work done, right? So that's one thing. The second aspect of this is that, when we look at public health, you can work on the entire population and bring a risk factor down, or you can work at the very end distribution, get the highest of the high risk, right? So if I had to focus right now, one would take your patients who already have established cardiovascular disease and talk about basic medications, right? Your statins, your beta blockers, your ACE and ARBs. Are we actually able to provide those medications? The answer is even those medications we're not able to provide, right? You look at the more recent data that came out of Pure study, about 20% of the people are receiving one of these 4 basic medications if they've had a heart attack or stroke. So even getting these medications on the essential medication list in these countries, right? Right now, a lot of these medications are not on those lists either. So even doing something like that, if a patient is going to a basic health unit, can we get them to be on a beta blocker if they had a heart attack? Can we get them to be on a statin if they had a heart attack or a stroke? I think even those little things will make an appreciable difference. So very, very basic stuff. I don't think we need to get too technical here.
Thank you very much. I think now is the time to open up the floor for questions, because it's not just for us to take the stage, but also for those who came and joined us for this Heart Cafe session on strengthening commitments to cardiovascular health for all. Questions from the audience?
Thank you very much. This is a fascinating discussion. I'm curious about two things. One is the impact of industrialization, increased income, nutritional transition, and what I'm getting at is sometimes that which we think brings prosperity might bring a lot of disease on the back end. And who's incentivized to, it's obvious that everybody's incentivized to make more money and to sell more things, but the question is who's incentivized and going to get wealthier, for example, because money is spent to prevent heart attacks and other things. And the other thing I'm wondering about is how do you balance that desire that you express to empower the community with the idea that there would be a national top-down approach, which could be a little bit at odds with empowering individuals. And I'm thinking about those two questions.
We'll leave the community question. I guess I can talk about the financing piece about healthier diets, if I heard you correctly. Is that what you were asking about?
It seems like as countries get richer, the diets get worse.
Worse, right. And I mean, and that's happening in a lot of countries that we're working in. And in fact, it's happening in the West as well, right? If you look at the US, you look at the UK, the same patterns are there. I don't think there's an answer to that that I have that's like a clear answer. What I have found important are two things. One is that as industrialization is happening, as migration is happening from rural to urban areas, there are two things that you can do which are under our control. One is, I think, providing choices. And when I say providing choices not just to the people, but actually people who are selling that food as well, right? That you can still make a profit if you leave some healthier options on the table as well. It's not going to work if you just talk about the people who are consuming that food. Yes, you can create pressure, but if you don't ever get exposed to healthier choices, you're not going to make those choices, right? So I think giving that option both to the sellers of the food as well as consumers of the food, and then doing this along with increasing awareness about the healthier options, right? I think that is one aspect of it where things, again, could be addressed. Those options need to be looked at. And then the second aspect of this is that the context is very different. Whereas here we may talk about food deserts in the United States, in some of these other countries, it's actually a very different kind of scenario. You have this concept of food streets, right? If you go to, especially in Asia, most of the Asian countries, you have these food bazaars, right, where you get all the unhealthy food. And actually people are living right next to these food streets where you have a lot of unhealthy food, right? So again, the question is that can you find ways where there are some healthier options that are available by working with these vendors and with the community to come to a consensus that we're not going to be able to get rid of these unhealthy choices altogether. That's probably not a realistic approach. Can we add a few options that still give that profitability to the vendor and allow the community to have some options that are healthier? I think that may be a good compromise that's financially feasible as well.
Thank you.
Just briefly on your question, just briefly, I think that the school environment is another place where you can work, as you said before, from the very beginning, the early ages. The school environment in terms of food and options to do more physical activity and change our habits from the very beginning.
Yeah, talking about the community, you can look at it from various aspects, and it goes to the example that I gave about cancer. And I think an earlier example is the HIV/AIDS movement. I mean, a lot of the progress that was made towards availing treatment of HIV/AIDS came out of advocacy from the general public. And the people who control the purse strings are, of course, the politicians. And the politicians, at least theoretically, listen to the voters. And therefore, you need this pressure to be coming from the voters. So our role as healthcare workers, as cardiovascular workers, is to adequately sensitize the general public about the burden of cardiovascular disease. Somehow, I have no idea why this is so, but we haven't done that as sufficiently as for example, the HIV community. I think that was quite self-evident. I was a young doctor when our wards looked like concentration camps. I mean, people were dying like fleas, so it was sort of self-evident. But like, again, the cancer community, it is something that sort of is emotional. People feel it. We have to find a way to make the public appreciate that, in fact, more of them are dying of cardiovascular diseases than all these others. It's not a competition between illnesses. It's that we have to take care of everything. I think that's the perspective from which I look at it, so that there is advocacy from the community itself.
Thank you so much. Yeah, you touched on our major challenge also at the World Heart Federation, when we communicate to the outside world about this 20 million deaths a year. Where do you, where is the middle ground between having that clear message that it's not perceived as an immediate threat, but actually it is? And talking about the lost lives versus a healthy living.
Yes.
And we just also talking on voting. I would like to encourage all of you first to let you know that we have a petition going on a global level, and we ask people to sign a petition for advocating for cardiovascular health. And we are taking all the signatures to the UN high-level meeting on non-communicable diseases later this year in September. And last thing I would like to say, and then I'll open the floor to one last question and one last word from you, is that we own it to the 500,000 people who are living with cardiovascular disease, and even more those who are at risk at cardiovascular disease. We own them a chance for a better future. We own them a chance because they deserve it, and because that's they're looking at us. I think the world is looking at us, and we as a community, the Heart team, we should do something about providing a chance for a healthy life for everyone, and nothing less than that. So I encourage everyone in your daily work to think about that aspect of going beyond the science and beyond your immediate research, and being the advocate for change in a world where 20 million lives are lost to cardiovascular disease every year, and where people, when asked what is the #1 cause of that, they talk about other diseases, or they talk about, terrorism or wars or other, devastating factors, but not the #1 killer in the world. Is there another burning question from the audience before I ask my experts for their last thoughts?
Hi, thanks so much for this really wonderful panel. My question kind of goes back to something Salim said earlier about the value of the broad medical team, right? It's not just doctors, it's also nurses and dietitians and partners. And I guess maybe I sort of want to take that one step further. Can you all maybe speak to the value of medical societies and civil society and advocacy organizations from the patient perspective, and how they are players in developing and executing CVD action plans and other awareness activities that really can help move the needle forward, like you were talking about, in terms of increasing awareness about the importance of the devastation of CVD?
Well, clearly, I mean, and we need all hands on deck, basically, and clearly professional societies have a major role to play. I think the weakness that professional societies tend to have is they become an old boys and old girls, society, where we talk about the technical things, which ARB's half-life is 30 minutes longer than the other, and that type of stuff, and we lose touch with reality. So I think the professional societies need to we need to get out of our comfort zone and talk to the public, and then talk to the broader civil society that are not necessarily professional society. So the bottom line is, other than our technical selves, we need to wear the hat of our advocacy selves.
And I can briefly add that we need communication skills.
Yes.
To really get to the community, to the politicians, and to other sectors, not only the health sector.
I mean, I'll just add, that I think even the way we look at any disease, and I'm not looking at cardiovascular disease, I think the onus is not just on the government. I think we need to even get that message out there that if I am living in a community and I know that people are, dying left, right, and center from cardiovascular disease, me being a member of the community, the power lies with me as well. So there's some of the work that's happening now where the researchers in very large settings work with the communities, and the incentives are that if we meet this target, we will come with half of the funding, and you come up with half of the funding. So we're going to change the roofs and all the homes we have in the community so they become a little bit more heat resistant. So heat related illnesses go down, right? So I think it goes back to what you were saying, that even the responsibility does not only lie on the government. And we know that a lot of these governments, and well, I should say perhaps most of the governments right now, are not in a very stable position to invest in health. I mean, that funding is going down in even the developed countries now, what has happened in the last 2 months. So I think civil society becomes even more important, community becomes even more important. I think the bottoms-up approach, what you need to do in public health and all that, I think then probably that can come from civil society and community. And what it comes in terms of making sure that your basic health units are all equipped with essential medications, perhaps that can lie with the government to some extent. And then that way we're working at both the actual healthcare system and the delivery of it at the facility level, but then taking it where it actually is. Most of the heart disease is in the community. It's not at the healthcare facilities. And then perhaps that's where the community, the civil society can come in. And I think the organizations like World Heart Federation, American Heart, American College of Cardiology, European Society of Cardiology, and a lot of those societies that are in this space, they permeate through the entire piece of it, whether that's advocacy or getting the community involved. So that's some thoughts.
Let me give you a challenge. Please stay with the mic. My last question requires a one-word answer. So could you tell us what is your vision for the future of heart health in one word?
Can I say 3 words? I mean, okay, good. I bargained. Do meaningful work. I think so now can I explain why?
Yes.
Achievement in life is important. It's very important to have achievement in life. But I think at some point, pivot has to happen to do meaningful work. So I am just going to say the word meaning, I think is extremely important. If all of us here sitting can say, what can I do that creates meaning in my life by doing good work, I think we can make some change.
Thank you, Vilma.
One word, team-based approach and involvement of the community.
Thank you. Elijah.
I'll use about 10 words. I agonized over this. Then I had a Damascus moment this morning when I remembered that we are in Chicago, and there's a famous American from Chicago who has got Kenyan origin who said that, yes, we can. So I think that working together, yes, it is difficult, but we can.
Thank you. Perfect. Yes, that's exactly what we're saying. Yes, it's possible.
You know, when Elijah, when you were talking about it, something came to my mind, which is very, I think, motivating, or rather than the word motivation, the better word is inspiration. Is somebody said this, which is very, very thought-provoking, which is, it matters what you do. It matters what you do. So do what matters. And I think that's what we need to think about in life.
Thank you very much. Thank you to all the panelists. Yes, we can. On that note, I invite you just to stand up and we have a group picture. And also the rest of the participants, if you're interested in hearing more about other topics, including cardiovascular health in women and the heart-brain connection and others, I invite you to attend all our other heart cafes. And also, please do sign a petition where we ask governments to take us seriously. Thank you.